We are now live. Hello, web shadowers, and welcome back. This is the 6th week of fall 2021, and we would like to thank you all for joining us this afternoon. Today, we have the pleasure of hosting Dr. Gui, who will be teaching us all about ophthalmology. As always, please remember that the Google form will be posted in the chat and in the description of this video when the session is over. With that being said, Dr. Gui, you may start whenever you're ready.
Hello, everyone. I'm Wayne Gui. I'm a retina specialist, and which is also an ophthalmologist, but a subspecialty of ophthalmology. And it's good to have you join me today. So let's get started. Let's see here. All right, so I'll just quickly kind of give a brief introduction to my path to ophthalmology and retina. I went to college at Cornell in upstate New York, and then after that, medical school at Yale, kind of still in the Northeast. And then for internship, I went to Harbor UCLA in Torrance in the Southwest in California, and then residency and fellowship at UCLA. So I kind of stayed down here, and now I'm at a private practice in Huntington Beach. And so you can kind of see in the map on the right that there are some arrows here, and it really shows kind of the path that I took. And it's not that atypical in terms of, for your training, you're often taken to different places around the country. And that's one of the things that, medicine kind of comes with the territory with medicine. So why did I pick ophthalmology? I really decided to pick ophthalmology in about between second and third year of medical school. And for me, just kind of seeing, the attendings in ophthalmology, I was really, really hooked for various reasons. One, there's an excellent combination of both medicine in the clinic and also surgery in the operating room. And I found that as I went through medical school, I really enjoyed the various aspects of surgery, during that time. You really make a meaningful difference in patients' lives. Patients often, say that their eyesight is, the most important sense that they have, and it's right up there with, the rest of their body. The worst thing that they can imagine often is either, losing their eyesight or having cancer. And so it certainly is, a big component of all of our lives, especially these days when, our lives are so visual, and, having your sense of sight is extremely important. In terms of, call, this is for, down the road, and, even in training for a surgical specialty, the call really isn't that bad compared to some of my peers who are in the more kind of general surgery or neurosurgery fields. And as an attending, when you're finished training, your call is really not that bad in most situations. Ophthalmology is compatible with a work-life balance. The compensation is quite competitive. And really, when I shadowed and observed and worked with attendings in the field, they were just, for the most part, very happy. And obviously we want to be happy physicians. We want to take care of ourselves, and only by taking care of ourselves can we really take care of others. So now, why retina? Retina is a very specific field within ophthalmology. And so in my opinion, I think that it has the most interesting pathology of all the different subspecialties. The treatments are also wide and fascinating. As a retina specialist, especially surgically, you're comfortable with most parts of the eye. So you're comfortable with the back part of the eye, which is predominantly what we deal with. But for any we call it anterior segment issues, you also have some proficiency. The images within the field are really really beautiful, anywhere from photographs to something called OCT to fluorescein angiograms, ultrasounds. The images are truly astounding. The surgery is also quite challenging. Oftentimes one of the jokes is, when kind of surgeries don't go the way they planned for other ophthalmology surgeries, you kind of just send it to the retina specialist. And really, you deal with a whole bunch of challenging cases, in addition to more kind of bread and butter cases as well. The surgeries also are relatively short. Retina surgeries, within the realm of ophthalmology surgeries are on the longer side, but compared to other, surgeries, surgical fields, it is still considered short. Typical surgeries range anywhere from half an hour to up to about 2 hours. And again, it's compatible with the work-life balance. There is competitive compensation, and physicians are happy, retina specialists as well. So just going through some of the images here, these are some of the giants and pioneers of the field. On the left is Dr. Charles Scapins. He is often considered a father of modern retina surgery and of the field. Top right, you have Dr. Gass, who revolutionized kind of the medical retina aspect of retina. And then bottom right is Dr. Robert Malcolmer, who co-invented one of the mainstays of surgery, the vitrectomy. And so I just wanted to kind of show some of the images. You have a model of the eye on the left. In the middle is a slit lamp, which is kind of the workhorse of ophthalmology in terms of the exam. And then on the right is an indirect ophthalmoscope, which I often use to look at the fundus, to look at the back part of the eye. And so here are some of those beautiful images that I was talking about. In the top left, you have a normal slit lamp exam of the anterior segment, which is the front part of the eye. In the middle up top is a fundus photograph of the left eye, centered on the center of the eye, the back of the eye of the retina, which is called the macula. In the top right, you have an OCT, which stands for optical coherence tomography, and it basically uses light to sort of image the retina in very high resolution. Bottom left, you have a fluorescein angiogram of the left eye. This is a normal one, kind of showing the perfusion and the vessels of the retina and the underlying choroid, another structure under the retina. And then in the bottom right, you have a picture of an ultrasound of the eye. And so those were more normal photos. Here are some abnormal ones. So in the top left, you have a slit lamp photograph showing what we call a hypopion, which is white cells, white blood cells deposited in the anterior chamber, the front part of the eye, and a very red, injected, kind of angry-looking eye. And especially if this patient just had surgery, you want to rule that patient out for an infection. In the top middle picture, you have a branch retinal vein occlusion, which you can see there are some hemorrhages that aren't normal, that weren't present previously in the other slide. And the veins of this eye are quite tortuous, and that's consistent with the backing up of some of the blood vessels there. Top right, you have something called cystoid macular edema, or CME, and basically you see those cysts within the cavities, within the structure of the macula. Bottom left, you have a fluorescein angiogram that is not normal, and it shows areas of we call non-perfusion. So the blood vessels really don't have the proper flow, and there is some inflammation and leaky blood vessels that allow the dye to leak from the vessels. And then at bottom right, you have a picture of an ultrasound that shows a mass, a tumor within the choroid. And so you can see, the images are very broad, and especially in retina, they are quite beautiful and very very fascinating. And so I know that if you follow this series, other ophthalmologists have kind of gone through a little bit about regarding the application for residency. And this is just a brief overview again. The application is through something called the SF Match. It's a 4-year residency program, and now there's really a push to integrate the first year, intern year, with sort of ophthalmology in general. It's an early match, so you get the results in February as opposed to March. It's a very competitive specialty. And in terms of the match rate, so those who apply and those who actually match, in 2021, it was 74%. And it's, if I'm not mistaken, it's kind of hovered around that number for a while now. There is an advantage if you are a US allopathic or MD senior. There's an 80% match rate. And in 2021, at least, applicants who were DO graduates actually weren't able to match. And you'll find that in the field, in general, there are a lot more, MD or allopathic graduates. Now, for Retina Fellowship, this is after your residency. It's a 2-year program, and I'm talking about Surgical Retina Fellowship. It's a 2-year fellowship program. Applications also through SF Match, and the match occurs in December. It's a very competitive subspecialty, and in terms of statistics in 2020, there were 110 total programs, which includes medical and surgical programs. And the medical retina fellowship is a 1-year program. And so there were some vacancies, but when you are applying for medical and surgical retina, in general, you want to choose programs that will allow you to have the best experience, the most cases, the most diverse patient population, so that you really hit the ground running once you come out of training. Because training is short. When you're going through it, it might seem like it's taking forever, but once you come out, you're really in some ways on your own. And so you really want to be immersed and be exposed to all types of pathology. So let's go through some of the cases, and feel free to ask any questions if you have any at any point, and I'll try to get to as many as I can. So case 1, this is more of a medical retina case. So chief complaint is blurry vision in the right eye. The HPI, history of present illness, is that this is a 32-year-old male patient who presents with a 1-month history of blurry vision and floaters in the right eye. And so, if the patient just presented to you that way, the differential diagnosis is extremely broad. And so, there's some other things that you would like to know, of course. So, what are some of those things? Well, here are some of the things that you would typically ask. So you want to know about their medical history. What systemic illnesses or issues do they have? So this patient has a history of systemic lupus erythematous with CNS, central nervous system vasculitis, history of diabetes, deep vein thrombosis, pulmonary embolism, hyponatremia, which is low sodium in the blood, and hypoalbuminemia, which is low albumin. And so right off the bat, you can tell that this patient, is or has been quite sick with various systemic issues, which can, present in the eye. POH is past ocular history, none. The patient doesn't note any. Family history, there's nothing of relevance. Past surgical history, the patient has had paracentesis, kind of sticking a needle to drain some fluid within a cavity, thoracentesis, lymph node biopsy, colonoscopy, and endoscopy. In terms of medications, the patient is on aspirin, atovaquone, hydrochloroquine, insulin, metformin, prednisone 60 milligrams, and cyclophosphamide, which is an anti-immunosuppressive agent. Allergies, the patient's allergic to sulfa drugs. And in terms of social history, the patient's a teacher and denies drugs or alcohol. So now, if you've been following the series and you know a little bit about ophthalmology, we are notorious for using acronyms and abbreviations. So I'll try to remember to clarify and define these abbreviations. So the vital sign of ophthalmology of the eye, the entire eye field, whatever field you're in, is vision. So you have to know what the vision is, and that's what's most relevant to the patient, and frankly, for your examination, you have to have it. So the vision in this patient is 20/40 in the right and 20/20 in the left eye. OD is the right eye and OS is the left eye. Pupils were equal, round, and reactive to light, and there was no APD or afferent pupillary defect. And that basically we reveal from what we call a swing flashlight test. And essentially we're looking to see if there is a gross sign of optic neuropathy or a problem with the optic nerve. So here, there is no APD. CVF is confrontational visual field, and so we use our fingers kind of, like this, and kind of check grossly to see what their visual field is, to see what their peripheral vision is. And in this patient, it was grossly normal. IOP is intraocular pressure. And so, there are a lot of nuances in terms of, what is a normal pressure, but, in general, for the average patient, a normal pressure is between 10 and 21. But of course, it's very nuanced, and we won't get into that in this talk. So in this patient, the pressure in the right eye is 16 and 19 in the left. Now for the slit lamp exam, and that's the exam where you use that instrument I showed earlier, and it's a workhorse of ophthalmology. The lids, we'll go through systematically the different components of the eye from the frontmost part to the back. And so the front, you have the eyelids, which were normal in this patient. You have the conjunctiva and the sclera, which is the conjunctiva is the covering over the white part of the eye. The sclera is the sort of white collagenous structure of the eye. It's white and quiet in both eyes. OU is both eyes. Cornea was clear. Anterior chamber was deep and quiet in both eyes. The lens was clear. And the vitreous, now the vitreous is the structure that occupies the greatest volume in the eye. And it's mostly composed of water with some macromolecules, predominantly collagen and hyaluronic acid. And so the vitreous, on at least the anterior vitreous on the slit lamp exam, showed some trace cell and haze in the right eye and was clear in the left eye. So right away, we know that something's going on because, the normal eye does not have any cell or haze. So here's an image of the retina. This is of the right eye, and it's an Optos kind of wide field photo showing quite a bit of the periphery. And this is not a normal image. So in the right eye, you see in the center here, this is the optic nerve. The nerve may or may not have a little bit of swelling. And then you have the vessels, and you can see one of these vessels isn't properly, doesn't have the proper caliber. It's actually thinner than usual. And then obviously you have these areas of hemorrhages kind of throughout, which are not normal. And you have these areas that are that look like cotton wool spots and are infarcts of the nerve fiber layer, one of the layers of the retina. And so this right eye is not normal. And here you can also see some evidence of those cotton wool spots, which are not normal as well. But you can tell from the asymmetry in the right eye and the left eye that the problem is a lot worse in the right. You don't really even need that much training in ophthalmology to recognize this. Here is an autofluorescence photograph, which basically shows mostly these areas of hemorrhage, these blood areas that are in front of what we call the RPE, and the RPE normally emits or has molecules that show natural autofluorescence, and so they're picked up by the camera, and so those are kind of throughout the fundus. You have normal autofluorescence, and these areas of hemorrhages are kind of in front of it, or not as deep, but more superficial to the RPE. In the left eye, grossly, this looks pretty normal for the autofluorescence. And so this next photo is a fluorescein angiogram. So what happens is we inject a dye, fluorescein, into the veins of the patient, and then we quickly take the camera and look to see, how the dye is transmitted to the blood vessels. And there's a normal pattern. First goes to the choroid, which is underneath the retina. And then it goes through the arterial system, the arteries, then to the capillaries and back through the veins. And so this is still pretty early. And you can see that the arteries are filling, but they're not, filling all the way. And in fact, one of the vessels here isn't filled. The other part that, with experience and with training, you'll notice is that there's not good perfusion within the capillaries. So there are a lot of areas that are dropped out. So there's non-perfusion. And you can see that here. These dark spaces are not normal. As well, you can see that there is some leaking kind of from these vessels. And so the vessels don't kind of hold the the fluid as well as they should. And the fluorescein angiogram helps you visualize that. And so the timer here also shows this is 9 minutes after injection of the fluorescein. So this is in the right eye. And in the left eye, there are some abnormalities here, around the optic nerve, but in general, it isn't as bad in this case. This is a picture of what we call an OCT, or an optical coherence tomography. And so it uses light to very carefully, in fine resolution, kind of resolve the different layers of the retina and even some underlying structures. And so this is in cross section for the eye. This part is the vitreous. So this is within the eye. This structure right here, kind of that has a dip, which is normal, foveal depression. This is the retina with its various layers. And then you have what we call the RPE, which is kind of like a pump, and also has natural autofluorescence, which I mentioned earlier. And then below that is the choroid. And so that these kind of bigger vessels that help perfuse and help nourish the retina, the outer part of the retina. And so the left eye is generally pretty normal here. The right eye, there are some areas of a little bit of thickening here closer to the optic nerve. So the image up top is the right, and the image below is the left eye. This is a view of an OCT angiogram, and it's a relatively newer imaging modality, and it kind of shows the various capillary systems within the retina. In the right eye, if you look here with the deep capillary plexus, we call it, there are some deficiencies kind of throughout. And this is the left eye, which is a little bit less affected. And so the differential diagnosis of retinal vasculitis, which is the inflammation of the vessels in the retina, which is associated with occlusion of blood flow that you saw with the non-perfusion, is quite broad. And so you have conditions such as Behçet's disease, Eales disease, multiple sclerosis, relapsing polychondritis, Rift Valley fever, lupus, Susac syndrome, syphilis, TB, varicella zoster uveitis, and West Nile fever. And so we won't go into all of the various possible diagnoses, but here, the big hint was that the patient, already came with a diagnosis of lupus, and so that's very helpful. Now, the diagnosis here, as I just said, is lupus, retinal occlusive vasculitis. And given the aggressive nature and the progression of the disease with severe non-perfusion, the plan was to add another immunosuppressive agent, Rituxan, to the cyclophosphamide and the PO oral steroid. 2 months later, the patient received 2 treatments of Rituxan and 2 treatments of cyclophosphamide, and the vision improved to 20/20. The anterior exam, the slit lamp exam, was unchanged. And then here is the fundus photographs. And so you can see that there are fewer hemorrhages in general in the right eye. The left eye is mostly unchanged. This is the autofluorescence. And with the fluorescein, there are some subtle changes, but, there seems to be more perfusion kind of around the macula, around the center of the retina. And so here, this is the OCT again, the right eye and the left eye. So, still maybe a little bit of disorganization here on the nasal side of the macula. Here is the OCT angiogram, and you can see that this area previously had more capillary dropout. It's actually recovered a little bit in the right eye after treatment with the Rituxan. And so this is the left eye. And so just briefly, lupus retinal vasculitis is our diagnosis. And lupus, interestingly, is Latin for wolf, and it was named because the rash was thought to appear like a wolf's bite. And so classically, lupus, in terms of the rash that you get, is what's called a malar rash. It's a rash kind of around the cheeks and around the nose. Now, treatment for this particular form of retinal vasculitis due to lupus is that aggressive therapy is required. Corticosteroids are a mainstay of acute treatment. NSAIDs and antimalarials can be used in mild disease. And then for long-term therapy, steroid-sparing agents are preferred. Immunosuppressants, such as cyclophosphamide, and biologics, which are also a type of kind of immunosuppressive agent, such as Rituxan. The other thing that you might consider is gentle targeted retinal photocoagulation. So you use a laser to apply to the ischemic areas to prevent a drive of forming new blood vessels and further complications. Any questions at this point? I know that that's a lot to consider on a Monday afternoon or Monday morning, but this is kind of just, I wanted to give sort of a flavor of what type of disease we see on the medical side. This is a little bit more rare. This is not your bread and butter case, but I thought that it was quite interesting. All right, so we'll move on to the second case, and this is a surgical retina case. And so this is kind of the other hat that we wear. In addition to being in the clinic, we are also in the operating room. And so the history of present illness is this is a 54-year-old female patient who had new floaters in the right eye 2 days prior to presentation. The patient was actually diagnosed already with a retinal detachment at another office 1 day prior, and is post-op day 1 status post, which means it's after having usually a certain procedure, status post pneumatic retinopexy. And what that means is it's an injection of a gas bubble into the vitreous body to try to, we call it tamponade, or to sort of close the break in the right eye. The patient was told that if there was worse fluid, subretinal fluid, after the procedure, they were to follow up. Ocular history: the patient has had basic refractive surgery in both eyes, had pneumatic retinopexy a day before, and has myopia or nearsightedness. Past medical history: none. And so, this is not so much a diagnostic dilemma, but rather a sort of, what you want to do for treatment. And so how this works is, and we'll talk about it a little bit later, but how it works is you want to fix the retina when it is detached, because it can, if it's not fixed, it won't fix itself. And, you often are blinded by the condition if it's not fixed in due time. So she refused an exam for the left eye because it was normal, and she wanted to be focused on the right eye. So the right eye, the vision was 20/100 in the right, and the vision in the left with pinholes was improved to 20/25. The pressures were 19 and 16. As I said, the patient declined an exam in the left eye. But in the right eye, there was 2+ injections. So there was some injected kind of red vessels of the conjunctiva. There was some subconjunctival gas. Presumably it was after the injection, some gas escaped through the perforation in the sclera. And there was 2+ NS cataract. So there was and NS stands for nuclear sclerosis. So she has some mild or to moderate cataracts, but that's not the main issue for her. The dilated fundus exam, or DFE, showed the vitreous having a 15% gas fill. So there was gas within the vitreous. This is explained from the injection that she got the day before. Optic nerve was 0.2 cupped at disc, which is a normal finding. The macula, which is the center of the retina, showed subretinal fluid. The retinal vessels were normal, and the periphery showed a regmatogenous retinal detachment. Regmatogenous means there was a tear or there's a break within the retina. Regmatogenous retinal detachment from 9 o'clock to 3 o'clock clockwise, counterclockwise, with subretinal fluid in the macula and a supratemporal break on sclerodepressed exam. So it's a mouthful, but basically her retina is detached, and she has a break that led to the detachment. And so this is an OCT image of the right eye. And so compared to the ones that you saw earlier, clearly this is not the same thing. The retina is elevated. This is the structure of the retina, and it is detached. So there is fluid underneath the macula, so underneath the center of the retina. And that is not normal. And how that fluid got there is, usually we have fluid within the vitreous body, once there's a break in the retina, the fluid can actually get under that break and cause the retina to kind of peel off. Kind of like if you think of your eye as a room, the wallpaper is the retina, and if there's a break, in the wallpaper, the fluid within the room can get under that and cause the whole wallpaper to be peeled off. And so that's what we're dealing with here. So the assessment and plan, this is a rhegmatogenous retinal detachment of the right eye. The patient is to continue to position to try to let the bubble tamponade that retinal break, and then return in a day to see if the fluid is worse or better. And so, this is one of the treatments. The pneumatic retinopexy is one of the treatments that can help and reattach the retina. But, if it really isn't improving, you ought to try other techniques. Looks like we have some questions. Yeah, so the question is, was the operation unsuccessful, or is this pretty normal after this particular procedure? And so that's a very good question. And the day after the procedure, the retina doesn't necessarily become attached right away. And so my approach was to see how it did the following day and potentially further. The decision making is basically, if the retina continues to improve or doesn't get worse, then I would follow it and continue to monitor and hope that it becomes reattached. However, as you can see here, the next day the vision was still poor, but there was a lot more fluid, and it wasn't just fluid kind of shifting around a little bit, which you can see after the procedure. The fluid got a lot worse, and it involved sort of the entire kind of inferior, the bottom part of the retina. And so it was my judgment to proceed to additional treatment to really reattach the retina. Another question was, how does a retina become detached? And so, I kind of went over that, but I'll go over again in case you missed it. If you think of your eye as sort of like the room that you might be in, and the wallpaper as the retina, and you think of your room, and you think of this room as having fluid within, which it does, in the vitreous body. What happens is, if there's a tear within the, eye wall within the retina, or the wallpaper of the room, fluid can get in, and the fluid within the room or within the eye can get under that wallpaper or under the retina and cause it to kind of peel off or detach. Now, how does the eye get a break? Well, there are various causes. Often it is associated with the gel kind of separating from the retina, which is a normal aging process, and that can allow when the adhesion of the vitreous is abnormal to the retina, it can, once it separates, it can cause a tear to form. There are other ways, such as with trauma to the eye, and other ways as well. That's kind of beyond the scope of this this talk. Hope that helps. Okay, so now we're left with an eye that's worsening after this pneumatic retinopexy, and so the plan was to do a pars plana vitrectomy. So what this is, and I'll have a video to show you as well. What this does is basically it's surgery, and we enter the eye and we remove the vitreous that's kind of keeping this break kind of open. We remove the vitreous, and we basically replace the vitreous at the end of the surgery with a big gas bubble to push up against the eye wall to sort of close the break. And also we use laser to further close the break. And so what that does is the bubble temporarily kind of keeps the retina attached, and then the laser forms scars to kind of close around the break. So in the future, once the bubble reabsorbs, presumably the scarring was strong enough to keep the break closed, so that even when fluid within the eye tries to get under the break, it can't, because there's a scar around it. There's kind of like a weld that you create. Let's see if this video plays. So this is not the video from this particular patient, but it highlights some of the similar concepts. And so let's see here. This is, we call it a pars plana vitrectomy. And so basically what it shows is there's 3 ports. There's a port top and right in the picture, which is an infusion line, which kind of keeps the eye infused while you operate. So we don't want the eye to collapse during the surgery, because what we're doing is actually cutting and removing the vitreous strands. And so we definitely don't want the eye to collapse, and that infusion line keeps the eye with good pressure. And so this is an eye that had a retinal detachment, and you can see that the retina is kind of flopping around. The instruments on the right is a vitreous cutter, so it cuts the vitreous strands. On the left, we use a light pipe, an illumination source to kind of see what we're doing, basically. And so you can see the retina that's flopping around, and so I cut the vitreous. Here, it's actually, I'm using a substance that's heavier than the fluid within the eye, more dense, or higher specific gravity. It's called a perfluoro fluid, and so, or perfluoron. And what it does is it can help kind of squeegee some of that fluid out from the posterior, from the back part of the eye. And so after that, we have perfluoron in there. I'm shaving the periphery of the vitreous right next to the retina, but not making any holes or any new breaks in the retina. This helps to relieve any traction, to prevent any further breaks down the road. And also, if over the breaks, it helps to relieve traction within that break to allow it to flatten properly. And so then after that, I apply laser around the identified breaks, and this helps create a spot weld all the way around the break, so that in the future it doesn't, minimize the chance of detachment. And then here, basically, I'm removing any last drops of water within the eye, and then we fill the eye up with a gas tamponade. And so the patient has gas in there, and that reabsorbs. And once the scar forms around the breaks, the retina stays attached. That's one of the approaches to reattaching the retina. So at the most recent visit for her right eye, her vision improved. You remember it was about 2100, pinhole is down to 2032. And you remember that picture of the OCT, it was all floppy, there was fluid under the retina. Well, it's fully attached. And this is a picture of the macula. And obviously she was very happy for that right eye. But there's more to the story, so that's not the end. In the interim, the patient did allow me to examine her left eye. And I saw that in the supratemporal area of the retina, there was something called lattice degeneration. And so it's kind of this abnormal finding that we sometimes see in patients. And it's actually relatively common, but in this particular case, she had a retinal detachment in the other eye. I wanted to minimize the chance of her detaching in this eye, and so I lasered that. However, after the time of laser, and until 7 months after her initial visit, though, she presented with increasing curtain effect in the left eye. And her vision was 2200. Prior, it was 2025. And lo and behold, she had a retinal detachment in this eye. So she's gone through a lot. In terms of the exam, so the most relevant part is that she had a retinal detachment extending from 9 o'clock to 3 o'clock counterclockwise, with fluid in the superior macula, and 2 retinal breaks that were identified at 10:30 o'clock over here. And so this is a picture of the OCT from that day when she presented with the retinal detachment in the left eye. And, you can't really make out all the details. And a lot of that is because there's retina that's obscuring the details. All this dark shadow, that's retina. All right, it looks like there's another question. Let me see if I can access it. Yeah, so the question is the surgery very painful for the patient? And the second part of the question is, what happens if the eye collapses during surgery? So another great question. So the first part is the surgery painful? So how the surgery works is, most retina specialists for a pars plana vitrectomy basically performs it under MAC anesthesia, which stands for monitored anesthesia care. So it's a type of sedation. What happens is the patient's not fully under, but they are kind of in a twilight sort of sleepy state. The retina specialist performs what we call a retrobulbar block, which is injection of anesthesia behind the eye to both prevent the patient from feeling pain within the eye and to kind of immobilize the eye. And so it achieves a lot for us to have this type of anesthesia. The patient in general does not feel much pain, if any, during the surgery, and afterwards the recovery in general is really not too bad. Now, what happens if the eye collapses during surgery? So that is one of the big fears for a retina specialist and any eye surgeon who does intraocular or surgery within the eye. We take we take a lot of precautions to prevent this. We always make sure that the infusion is actually infusing in the proper place within the eye. And if the machine, for whatever reason, does not, operate or it malfunctions, we clamp the line, we stop the line, so we prevent fluid from egressing or leaving the eye. And if necessary, we would take a needle and manually, inject fluid into the eye. Saline solution. And so we take all precautions and all necessary measures to prevent this from happening. But it is something that you want to be aware of when you're performing the surgery. All right. So going back to this case, so now she has a retinal detachment in the other eye. It's really, really bad luck, but we have a plan. So the plan is, in this case, we're going to do a pars plana vitrectomy and a scleral buckle. And, we won't talk about kind of the nuances, and that's kind of beyond the scope of this talk, but it's another technique, the scleral buckle. And what that does is it helps indent the eye wall closer to the retina, and that also further is believed to help, prevent further, detachment down the road. So this is a picture not of this patient, but of another patient who had a pars plana vitrectomy and a scleral buckle. And so, this in general, I perform these under general anesthesia. It's a little bit more painful. What you can see here is that, in the beginning of the case, we open up the conjunctiva, and then we put these traction sutures over the intraocular to hook the muscles and to give us control for the scleral buckle. And then the next part, the 3 ports, as you noticed from the previous surgery, the retina is detached here. It's not as floppy as in the other case, but certainly you can see that on the nasal side on the right, it is detached. Here is the perfluoron again, that heavy liquid. So you can see that the retina is flopping around and there's a retinal break right there. So I'm shaving very carefully around the retinal break to relieve any traction, because we don't want that break, we don't want that hole to stay open. We want it to close. And that's the whole point of retinal detachment surgery. We want to close the breaks. And so here, I am visualizing kind of the rest of the retina and applying laser over that retinal break, all the way around the retinal break. And so then now perform what we call a fluid air exchange. So we replace the fluid with air, and the air helps push out any subretinal fluid, the fluid that accumulated under the retina, pushes it out through the break or the breaks. Meanwhile, the heavy liquid from the bottom already squeegeed out fluid from behind the break. So we kind of attack it from both ends, from behind the break and from in front of the break, so that we, decrease the amount of fluid as much as possible. And so here I applied a little bit more laser. The visualization in terms of the periphery is a little bit improved when it's under air. And so here's additional laser that's applied. This is that other step of just removing the last traces of fluid that's in the eye. And then this is the part of the scleral buckle, okay, where we place the silicone band all the way around the eye. And this helps, and this is that band, it's sutured in place, and it helps kind of minimize the risk of retinal detachment down the road. And then at the end of the case, we trim off the ends of the scleral buckle. We make sure that, we remove last bits of fluid, inject the eye with gas, check the pressure. And then at the end of the case, this is kind of what it looks like after the conjunctiva is sutured back in place. Looks like we have another question. Let me see if I can answer it for you. Did something from the right eye cause the retinal detachment in the left eye, or was it more spontaneous? That's a very good question, because you would wonder, right? So it's not something that happened in the right eye that caused it. It isn't a direct causal relationship. However, patients who have a retinal detachment in one eye often have an increased risk of retinal detachment in the other eye, and has more to do with kind of the intrinsic sort of nature of the eye and the risk for retinal detachment. Risks of retinal detachment, one of the highest risks is myopia or nearsightedness. Exactly. So the other question is it more common to have retinal detachment if you already have one, have it in one eye? Yeah. So it's a little bit higher risk. And so that's why, important follow-up, and, when a patient has new symptoms, new flashes, new floaters, a curtain of their vision that's, missing, they have to come in right away to be evaluated. All right, so let's move on. Let's see here. So at the last visit, post-op month 2, after the vitrectomy and the scleral buckle in the left eye, the patient's vision pinhole to 20/32. So certainly much improved. And this is the OCT. So you can see that the macula is fully attached and the patient is happy. So, retina is a very specific field, and, certainly it's, something I love. And one of the pieces of advice that I would want to give is, no matter what specialty you pick in medicine, pick one that you really love, so much so that the work doesn't really feel like work. When I go into work every day, I don't really feel like it's work. It's something that I'm paid to do, something that I love to do. And, ultimately I would recommend for you to find something like that, whatever field it might be. It doesn't have to be surgical. Obviously it doesn't have to be ophthalmology, it doesn't have to be retina, but if you do choose those, fields, then, good job. But yeah, you can pick, whatever you like, and that's kind of the most important thing. I have another question. Would the risk of retinal detachment be even higher with progressive myopia? So progressive myopia is not necessarily a term that we use so much. Myopia or the nearsightedness can progress and it could get worse. We often think of it in terms of whether it's high myopia or pathologic myopia. And the definitions vary a little bit, but pathological myopia typically has certain findings that make it kind of push it within the realm of pathological myopia, such as a staphyloma, which is kind of an outpouching of the retina of the eye, actually in the back. And so, yes, the higher your level of myopia, the higher the risk for retinal detachment. So it's very important to get regular eye exams, and especially if you have symptoms of flashes, floaters, vision loss. So as I said, pick a specialty you love, and if you do that, you can minimize any regrets that you might have. And it's a long road. There's going to be ups and downs through the entire path. If you want to be a retina specialist, you first go through medical school. First college, medical school, then internship, residency, and fellowship eventually. So, it's a long road, but certainly it's very rewarding if you love what you like to do, and patients are very, very happy or grateful for what you do for them. So, thank you for attending. And also, if you're in the Southern California area and you're interested in some in-person shadowing opportunities, feel free to reach out. You can email me at the email address you see there, or via Instagram as well. Let's see, it looks like we have one more question here. It says, is it possible to prevent retina thinning? Yeah, so, in the broad sense, no. It depends on, but it depends on kind of what, what disease or what process is causing retinal thinning. And there are various things that can, cause retinal thinning. One of the sort of hottest fields in retina today is actually coming up with a treatment for something called geographic atrophy. And it's something that we often see in patients who have a disease called age-related macular degeneration. And so these patients have progressive worsening of their central vision, and there's atrophy or thinning of the retina. And the ideal drug candidate would be a long-lasting treatment to, one, prevent the thinning, and two, to reverse the thinning so that the patients can see better. So, I wouldn't say 100% that you can't prevent retina thinning, but it depends on kind of what angle you're looking at. What's your favorite? So the next question is, what's your favorite part of being a physician and why? So honestly, it's really making that meaningful difference in patients' lives, and having patients and trust in your in your care. And it's very gratifying when you are part of their lives and can improve their vision, or save their vision, or even be there for them. Sometimes there are conditions in ophthalmology and within the field of retina where there aren't any good treatments right now, but just by being there for them, coming up with a diagnosis, talking with them, and even allowing them to feel like they're being listened to, that's already a lot for the patient. All right, are there any other questions that I might answer? It looks like our time is pretty much up, but yeah, if you want to reach out, I'm happy to see if we can answer any more questions for you, or if you are in Southern California and want to swing by, we can see if we can schedule or arrange something.
Thank you so much, Dr. Gui, for presenting for our web shadowers this afternoon, and especially for all the visuals you included. We loved all the videos. It was a pleasure to have you.
All right.
Everyone, please make sure you check out his socials. His Instagram is Wayne Gui MD, and also remember to reach out to him if you're in his area.
All right. Take care, everyone. Have a good day.
Have a great day. I'm posting the form in the chat, and it'll also be in the description of the video. Thank you all for